Good evening, everyone, and welcome to our third Parent and Caregiver Education webinar, Neuropsychological Assessment in Pediatric Onset Epilepsy, from Cognitive Capacities to Quality of Life. My name is Gretchen Knob, and I'm the Regional Director of the Epilepsy Association of Western and Central Pennsylvania, working out of our Camp Hill office. I would like to thank our generous sponsors for this webinar series, Greenwich Biosciences, LivaNova, Zogenix, Neurelis, Aquestive Therapeutics, and UCB. I would now like to introduce our speaker. Claire Flaherty, PhD, MS, ABN, is an associate professor of neurology and clinical neuropsychologist at the Penn State Health Milton S. Hershey Medical Center. She has over 25 years of experience in clinical neuropsychological research, including a multitude of clinical trials. Her clinical interests include a focus on frontal lobe changes in epilepsy, including the long-term cognitive behavioral consequence of juvenile myoclonic epilepsy and the potential benefits of responsive neurostimulation on executive functioning in intractable temporal lobe epilepsy, excuse me. Dr. Flaherty is board certified in clinical neuropsychology by the American Board of Professional Neuropsychology. Okay, so I am now going to turn it over to Dr. Flaherty for the presentation.
Well, while you're getting that set up, I just want to thank Gretchen and thank the organizers for allowing me to present this evening. I think you'll notice as I continue that I am a lifespan neuropsychologist. I have never focused on peds or adults or geriatrics. I really felt that it was important to know all stages of life to understand each of them. So you will see some of the focus this evening is going to be on pediatrics, but this work has really helped me understand better the adult and geriatric patient. So I'll just give you that as a prelude. It's really hard to understand people as adults living with this condition since childhood. We haven't really worked with children, understood the developmental challenges of the condition. Okay, so if you want to go to the next slide. Okay, so yeah, historically, neuropsychology and epileptologists have really had a very close-knit relationship going back to probably the turn of the 20th century. But certainly by the 60s and 70s, there was a mutual benefit from neuropsychology working with epileptologists to help them understand brain mechanisms, and for the neuropsychologist to understand certain regions that were intimately related to epilepsy, like the temporal lobe. So as I'm sure many of you realize, the most of the patients that are surgical candidates prior to some of the more advanced conditions approached by things like RNS, the classic temporal lobe epilepsy patient was a patient that was developing and manifesting seizures that were local to the temporal region. So that the neuropsychologist helped the epilepsy specialist understand what those regions were responsible for and how to approach the patient both before and after surgery to help them with quality of life. So if you want to go to the next slide. Okay, so.
Oh no, I'm sorry. I thought
this is fine, right? This is a good.
I apologize.
This is where I want to be right now, the next one.
Okay.
Okay. So
Yep.
I'm just trying to go through the mutual relationship we've had in the past, the two fields. All right. So with neuropsychology's looked at brain development. So again, from the neurodevelopmental perspective, we have looked at how brain development will affect the aging process. And in terms of how it was applied to epilepsy, the early procedures to evaluate for language and memory were the angio-WADA exam. This is an exam that involves taking a patient down to an operating room and actually putting to sleep one side of the brain, while the neuropsychologist is able to evaluate the other side for language and memory. So this is done where you look at the healthy side first to make sure you get the best look at the healthy side. and then you let that wear off, and then you go and you treat the other side of the brain, and then you evaluate the side that has the seizure focus. And it helps us determine which side is involved in language and which side is involved in memory for purposes of surgery, and whether or not it's safe to actually affect areas that are involved in speech, language, and memory later on. So in more recent years, this has been replaced to an extent by Fmri. Fmri is a way of looking at the brain's activity. It's not as invasive as the WADA exam, but it is at this point effective in looking at the language areas for activity. What I'm showing here is, I don't know if you can see my arrow, but I'll talk about the language tasks. So in the language tasks, you can see the activity there, like around the middle of the brain there. And as you have a person in the fMRI scanner, well, their brain is lighting up with activity. So you have them do language tasks like naming and thinking about words that start with a certain letter or words from a certain category like animals. And you'll see areas that get activated by that. At this point, fMRI is not that reliable as a way to localize memory. So the WADA is still the best way to approach trying to figure out which sides of the brain are responsible for verbal and nonverbal memory. But the fMRI eventually will take the place of that. It's less invasive and it's more accurate. Okay, next slide. This is another approach to evaluating a patient who has a seizure focus on the left side. So there's a concern about the language center being affected by surgery. These are, of course, the focal epilepsies. I know that many epilepsies are not, but right now I'm just describing historically how the neuropsychologists worked with the epileptologists. So this is a depiction of a neuropsychologist involved in the surgical procedure. The patient is draped there. You can't see the person's face. The actual surgical team is behind that drape, and they're moving up the brain with a probe while the neuropsychologist is having the patient speak. And when the speech becomes garbled or unintelligible, then the surgeon knows they can't go to that area. It helps develop the boundary where they can actually do surgical intervention to remove a lesion without affecting the language area. So that's this is how that is done in the operating theater. Okay, next slide. Now, phenotype is just what something looks like. The genotype is the genes responsible for what the actual protein product, and phenotype is typically what something or an individual looks like. So, for example, having genes in your family for left-handedness, your phenotype would be left-handedness. All right, so that's what that word means. Now, there was a time when the classification of epilepsies was very much involved in what part of the brain the seizures were emerging from. So lobar site. So if you had frontal seizures, you had temporal lobe seizures, or occasionally parietal lobe seizures, it was presumed that the difficulties you were having would relate to that particular brain region. That's true to some extent, but not anymore. It's understood better to be more of a network. But let me give you some classic examples of things that are still considered to be current. This is a depiction of memory. Long-term memory is compartmentalized into things that are procedural, like knowing how. That is partly to do with the cerebellum. It's also part of the temporal lobe and to some degree the frontal lobe. Declarative memory is knowing what. So it involves naming and general knowledge fund, things you might have studied in school, the things you might have learned as a hobby. And episodic memories are in a different area of the brain, and they're involved in personal recollections. So autobiographical memory is part of episodic memory. And as you can see in the picture of the brain there are a lot of different regions involved in the encoding and storage of memory. Memory is pretty much widely distributed, and I think it's believed that in evolutionary terms, memory is distributed widely to preserve it. So if you have an injury somewhere in one particular area, you're not going to become unable to remember or store new information. That takes a very large area of damage. So memory is pretty widely distributed. And older memories are more deeply embedded, and they will be stored a lot longer than short-term memory when there's a problem with memory. The amygdala is also an area for emotional memory. I like to tell patients that the amygdala never forgets, so that when you have an early experience that's adverse, like a typical child running out in the street to get their ball for the very first time, and they hear brakes screeching, and they look up and there's a car 5-6 feet in front of them, that there's a part of our brain that will never forget that experience. They will always register that as threatening. So that the next time that child runs toward the curb, that child's going to go into red alert. The brain is just going to do a reenactment, realize that this is dangerous, and get that child's attention, and just bring it to like a sense of threat. And so it will respond and not run out again. If we didn't have this, we wouldn't be here talking about this today. We wouldn't have survived as a race. Okay, so it has its place. The other region that's important is regions for short and long-term memory, semantic and episodic. As you can see that little circular area, it's very widely distributed through the temporal lobe. And the cerebellum is procedural. It's today known to be a lot more intimately related to the frontal lobe than it was once understood. That's an area that I researched. So it's thought that every area in the prefrontal lobe has a complementary area in the cerebellum, that at one time before we had a large frontal lobe, the cerebellum was managing all those things like attention and concentration. And so it's also intimately related to language. As I'm speaking now, my language is flowing out of me. And if I think of an unusual or a novel thought, I'll be able to continue the flow of those words. And the cerebellum, which is a motor area, is also involved in the continuous flow of conversation, and it has that function too in creative thinking. Okay, next slide. If I'm going too fast, somebody can shout out to me. I just want to make sure there's time for your questions. So the current perspective on how changes in the brain affect our functioning is a lot different. It's not a sense of like, well, this is happening here, or this is happening over here, all right? We understand the brain now is designed with a lot of interrelated networks. So somebody with temporal lobe epilepsy, for example, they're going to have difficulties with memory. They're going to affect areas that impact on the IQ. They'll impact on their language. They'll also impact on sensory motor skills, as well as executive functions. I mentioned, I have a reference down here that is from 2004 to illustrate the fact that this has been in the current mode of thinking for the last 20 years. So we understand now that we have these widely distributed networks, and that when you have a problem in one area of the brain, it can affect many different functions. The upside of that, though, is that one area of injury or one area of insult in the brain is not going to affect something all that deeply or totally, because things are widely distributed. Okay, next slide. So just as I mentioned, temporal lobe epilepsy being widely distributed, if a person has seizures coming from the frontal lobe, it will affect attention, which is classical thinking. It also will affect language, sometimes basic language skills involved in attention and processing, but also higher level language. When I say higher level language, I mean the creative thinking, things that are novel, not just the things that we learn in school, like basic naming of things and grammar. Frontal lobe epilepsy can also affect memory. This is sometimes indirectly through attention and concentration. It also can be involved in the area that's an overlap between emotion and thought. So if we have a very little initiative, motivation, and drive, it will affect our memory. If we're not interested in something, we may not put forth the effort to remember it. And of course, the frontal lobe is going to affect executive functions. That's going to include our psychosocial adaptation abilities. That may be, again, intimately involved with thinking as well as emotional processing. If we just don't have the interest, if we sometimes have difficulty with social skills, even if our IQ is totally unaffected, we may have difficulty understanding social context of things and be socially awkward. That can affect our ability to adapt. Okay, next slide. So this is you can go back to the 2017 classification. We are one slide ahead.
Oh, I apologize.
That's okay. Slowing down my New Jersey talk here. I'm not talking too fast, all right? I'm trying to maintain here. So this is the current thinking as of the 2017 international classification, that neuropsychologically generalized epilepsies, now we're moving away from the localized, as in temporal or frontal, to generalized epilepsies, because many epilepsy conditions are not that localizable. They can be general, and I'll explain how that's driven by, to some degree, by genetics. If there is a genetic vulnerability for seizures, these will emerge typically in childhood, and I would say typically in early adolescence. The early onset might be a few years before adolescence actually onsets, but as it is, puberty actually begins about 2 years before there's any physical change in the child's body. So parents will often recollect, a child having a year or two of irritability and grouchiness and just uncooperativity before they actually emerge into puberty. Those are the hormonal changes that are actually setting the stage for that. And that's when you might start to see some subtle changes in a child with a genetic vulnerability for generalized epilepsy. And these conditions, as you can imagine, will have a wide impact. They can affect attention, language, memory. They can be visual spatial skills can be affected, and that can amount to left-right confusion or difficulty organizing complex visual. I note that it's relatively spared in familial cases. What I mean by that is if there's actually a lot of epilepsy in the family and it's really well isolated, then there tends to be less visual spatial difficulties. And I don't think that's well understood. I believe it might be because the condition is much more localized. In a sense, it's not hitting the visual spatial area of the brain for that level of processing. And it also affects executive functions. I don't want to get flippant about it, but I often, tease neurologists that when we are compartmentalizing things and we're localizing things and we're talking about this region or that region, or even this neurotransmitter or that neurotransmitter, the brain is not listening because everything is working in consort. And when one thing is disrupted or one thing is out of equilibrium, everything is affected. So this makes a lot of sense to me that when you have a generalized epilepsy, you may have difficulties in any of these areas. Now, I want to be really clear that I'm not saying that you always will. There's a potential here for wide impact, but it may be any one of these, which is one reason why it's difficult to characterize generalized epilepsies. There is a certain pattern we can see, but individuals are just that, individuals. Okay, next slide. So one of the approaches that neuropsychology has taken to continue their work in the field as a partner in teamwork on epilepsy is to pursue things that will, the term is concordance. So let me explain what that means. In a sense, what we try to do is we try to get 3 different approaches to the same result. So that if the image I'm showing you here is functional neuroimaging. So if you see the over on the right, there's a little yellow box inside that brain slice. That's showing the activity level. So the yellow going to orange is low activity to high activity. And so with different slices of that brain on the right, those 3 brain slices are all lining up to the same area in the temporal lobe. So over on the left, down below, there's another type of imaging. It's an MRI. It's not functional, and it's showing the anatomy. And the anatomy that's not healthy in that picture on the left with the arrow showing the white spot there, that's in the exact same region as the area that's showing low activity. Then up on the top on the left is an EEG image. This is a more so it's just a fancier version of getting EEG where you wear an actual headset. It's like looks like the old baiting caps, and it has all the leads that are in the cap. And so this is the kind of picture you get from that. And in the area where you see the white, that's the lowest activity. And the arrow on the very left is the EEG. And that spiking that the arrow is pointing to is in the exact same region as is shown in the neuroimaging. So the goal of the neuropsychological evaluation would be to demonstrate difficulties in the brain regions we know that are responsible for cognitive abilities in those same regions. So often when I do an evaluation of patients, I'm what I would call blinded to the rest of it. I don't take a look at what the MRI and fMRI look like, or even the EEG. I do my evaluation and I determine what I think is the pattern of change in this patient before I look, because that gives me a more objective view of my findings to interpret them. And of course, the ideal situation is where all of these line up and we say, yes, this is where that lesion is. And so it gives the surgeon a lot more confidence if he decides to pursue surgery. That's, of course, a joint decision made with the patient and their family. But if this is how we approach a surgical candidate to determine the best candidate for surgical relief of their seizures. Okay, next slide.
Oh dear, sorry.
Whoops, that's okay.
There you
So the historical perspective on, now what are comorbidities? Sounds like such a daunting term. So we call a morbidity a condition. So as opposed to mortality, which is, a person's demise. So morbidity is a condition that you live with. And if there's more than one, there's always this determination of whether they are isolated. The person just has these two conditions that are not related at all. Like, for example, having asthma and also having an allergy to, that's not a bad example, an analogy, right? So having asthma and having hypertension, okay? Those are not going to be related, but you have two conditions. So the question about the comorbidities in epilepsy is, what is the relationship between the things we often see in epilepsy that go along with seizures? So individuals with recurrent seizures that are, I want to say typically, often when you have a clinical seizure, there are some subclinical seizures. If you measure EEG in a patient, you'll often see subclinical spiking, even though the person is not having a seizure at the moment, okay? There's also going to be, as I mentioned, the interictal EEG abnormalities. Interictal means they're not having a seizure. A seizure is an ictal event. So if you're you're just in between, and you may still see some EEG problems. Then there's the effects of the anti-epileptic drugs, that's an AED. And then there are psychosocial complications of having seizures. As all of you are well aware, whether you're a family member or the patient, it just wreaks havoc on your life to have a seizure condition, particularly when it comes on in early life to puberty. I'm really not sure as a clinician what's worse, having seizures in childhood or having them as a teenager. But certainly it affects the developmental course more if you're a child with a seizure condition. So the early thinking was that there was this unidirectional relationship. I have actually been to meetings, I'm not going to go on a tangent, I promise, but I've been to meetings like back in the 70s and 80s where people would have shouting matches at meetings. They would really be there was such a heated argument about this, of whether any of these conditions that often were seen in epilepsy were related, whether they were the consequence of living with a seizure condition. And some of these were medical / somatic, meaning they were pain conditions, something to do with the body. The others were the cognitive complaints that patients often have. And then the emotional, sometimes psychiatric concerns that patients would often have. Then the social interpersonal difficulties, like difficulties with work, with finances, with medical management, with getting along with other people, including their family members. So the early thinking was that this was unidirectional, that the having seizures would lead to these other complications when they presented. And again, this is individual. Some patients don't have all of these difficulties or any of them, but most patients would, when they did show up with a comorbidity, with a separate problem, it would be in one of these four categories. Okay, so next slide will show them the current thinking. Okay, so currently with a lot more understanding of medications and medication effects, and again, looking at networks rather than like one isolated area of the brain, and a much more advanced understanding of genetics, it's now recognized that these conditions are co-directional. So a person can present with emotional difficulties before they have a seizure, their initial seizure. They can also have cognitive difficulties before their initial seizure. There can be other medical conditions that are related to having a risk of vulnerability for epilepsy, and then the epilepsy will emerge later. And sometimes people have social and interpersonal difficulties. Their emotional state's not that balanced for quite some time before they have their first seizure episode. So these are all possible related conditions that are now recognized to be associated with the risk of having a seizure condition. So next slide. Okay. So there's some variability whether you're looking at adults and children or whether you're looking at children. So with adults, the new onset, you may see cognitive difficulties for 1 to 5 years with memory, executive functions, and psychomotor speed. I want to be careful here because psychomotor speed is affected by medications. But when the conditions come on, they can affect psychomotor speed. So you have this double whammy, essentially. The person with the seizure condition may have some slowing of psychomotor speed, but medications will definitely affect that in a significant way. So I've seen this pretty much with any epilepsy medication that a person is on. And they're necessary. I'm not recommending anybody ever go off their medication, but they have to live with the fact that the medications are going to slow down their psychomotor speed so that they're slower in doing hand-eye tasks, and sometimes even slower in their thinking, their thought processes because of medications. But there's also some effect on their psychomotor speed that is a cognitive difficulty that can emerge before their first seizure event. Now with children, what we tend to see are behavioral difficulties. Those can include attention deficit, hyperactivity, depression, anxiety, and academic struggles. Those are the typical things you will see sometimes before the first seizure event, sometimes co-occurring after the first seizure event, and sometimes made worse by having the seizure condition. Okay, so I want to give you an example of one patient that I had the privilege of evaluating about 2 years before her first seizure event. And prior to that, she really had no difficulties, no medical conditions, no behavioral difficulties, very bright student in a private school. There was just nothing, to speak of, really. She was what the neurologists would call unremarkable, right, before I actually evaluated her for some difficulties in school. So she's starting to have trouble with language arts and math, kind of unspecified. There was no obvious learning disability. There was just a general difficulty. It might have been attention. We weren't really sure what was going on. So she was 11 years old. So that's the family background. 2 sisters. They have a couple of guinea pigs and a dog. Like a typical family. There was nothing really going on psychosocially there. It was a stable home. Okay, next slide. So here's the family history for this child at the age of 11. She's from an intact middle-class family. Her mom has seasonal allergies and she has chronic sinus infections, but nothing else. Dad has congenital heart condition that apparently was in his family. The genetics were there for that. Her older sister had asthma and bipolar disorder. In her mother's family, she had uncles that had hypertension. One had coronary artery disease. One had a brain aneurysm. And in that same family, there was a sister, one of our aunts had a brain aneurysm. One aunt had lupus, and one had depression. On her father's side, she had an uncle who had leukemia very young and passed away young. Another uncle who developed pancreatic cancer as an adult. In her cousins, she had 2 siblings, one with seizures and one had learning disabilities. This was if you look at the maternal uncles, this was another uncle with he had no history of medical conditions, but his children included a child with seizures and a child with a learning disability. And you can see the grandparents there, and I put in purple those people who had passed already, just to see the history. It's really not a telling history for developing a seizure condition. It's pretty, I would say that, in the American population, things like depression, alcoholism, hypertension, there's a very high incidence of them. There's nothing specific about these. All right, the next slide. So this is the interview. Initially, this is a child that was alert, oriented, pleasantly cooperative child, well-groomed, well-dressed, casually dressed, but well-dressed, very articulate, obvious that high IQ, average range IQ from just listening to her. She's very articulate, very well spoken. So I went through a classic pediatric evaluation. The NEPSI is a very extensive evaluation for children. It begins at the age of 3, it goes up to 16. So you have core measures and you have expanded measures. You can pick and choose what you want, and I pretty much went through most of it. The Ray figure I showed earlier, I didn't want to belabor it because I knew I was going to talk about it later, so I'll talk about it now. It's a complex figure that's been out there since the 50s. It's a very nice way of looking at visual memory, but also visual organization. And it's a type of learning too that is not primed. So we ask people to copy the figure without any warning that they're going to have to remember it. It's a passive learning type of test. Then we just ask them a couple of minutes later without any warning with a blank sheet of paper to please draw what they remember of it. Then we do the California Verbal Learning Test, which is 16 words that are read to the child 5 times. They have to give back what they remember of them each time. Then we go back later and ask about 3 minutes later, and again, 20 minutes later, what do you remember? We also had behavioral checklists. We had filled out by the parents, herself, and her teacher. And then we have a depression inventory. If anybody's ever heard of the Beck Depression Inventory, Kovacs is one of Beck's students and developed a child's inventory based on Beck's depression inventory. All right, next slide. So don't worry about this busy slide. Just look at the arrows, okay? If you want to glance up at over on the right, you can see that everything is average to low average. There's some high average in there. There's quite a few high average range scores. And that's, I just covered the attention, executive skills, language, sensory motor, and visual spatial, all right? Now look at memory. So her narrative memory, which means I read her a paragraph, this is from the NEPSI, and she had to tell me back exactly what I had just read to her. And that's borderline. Then I went through a flip chart of memory for faces. I just showed her faces of children, like multiple faces of children. I just said, remember this one, remember this one. Then I took another book that had twice as many faces in it. And there's 24 in the first book, and then there's 48 in the second book, and asked her, after having a 2-second exposure to them, to tell me which ones were the ones she just looked at. And that's 95th percentile, which means out of 100 people her age, 95 would have done worse. Whereas the narrative memory story was 5th percentile, meaning 5 people out of 100 would do better. So did I say that? Yeah, 5 people would do worse on it. It's really low. And then the memory for names was somewhere in the middle. So this was pictures of children, and I tell her the name. This is Jacob, this is Maria, and she has to then tell me. I shuffle them, show them her faces again, and she tells me who it is. And if she can't remember Jacob, I'll say this is Jacob. So we go through that 4 times. I go back later and show her the faces and ask her, okay, what's his name? And so that's a little bit better, but not that great compared to what she can do in other areas. So her visual memory, when I look at something, I've got it, is in the superior range. But when it involves the language centers, it's not that easy to do. So that was kind of a telltale sign for me of where things were going on. Okay, next slide. All right. This is the rest of this is the expanded NEPSI. These are executive skills. So one is called statue, and you just have the child stand with their eyes closed and their hand is, one hand's on the table, the other hand is like they're holding a flag. They have to stand like that, their hands on the table. And then you tell them to close their eyes and just stand there. And then we have a set of instructions that, the examiner, we have to drop a pencil, we have to cough, we have to say things like ho-hum, and the person, her job is to stand still and just be a statue. And she couldn't do that. She was opening her eyes, she was giggling. It was very, very difficult for her to just block out distractions. Knock and tap is an executive test where the hand's on the table and they have to follow a sequence. I'm doing this, and their hand has to do what I'm doing. And then at one point I say, okay, when I knock, you tap, and that was difficult to do. Okay. The other thing that was difficult was verbal fluency for words from the temporal lobe. Semantic is where we have category words like animals, fruits, things found in the kitchen, flowers. That score for semantic was above average, greater than 75th. That's where the scale ends. When I asked phonemic, which is the frontal lobe, tell me words that start with F or S or R, that was difficult. It wasn't that terrible, but it was considered borderline for a child. Manual motor sequences were a little bit more variation on this frontal lobe test. They're just having the hands have to do certain things, all right? Manual motor like this. different things. And that was hard for her to do. Block constructions also is a three-dimensional blocks. So I'm narrowing this down to the frontal lobe and the parietal lobe. The parietal lobe is involved in 3D blocks. It's involved in spatial perception, and it's also involved in how we process what we hear on the left side. The right is for the visual, and the left side is for the how we process what we hear. So I'm getting a sense of there's something going on in her parietal lobe and in her frontal lobe, primarily on the left. Okay, next slide. This is the California Verbal Learning Test, which involves the frontal and temporal lobe. So here's the 16 words. Trial 1, she's at the 94th percentile, it's superior. Trial 5 is high average because at that point she's got all 16, so she kind of plateaus. So you can't get any higher. So it ends up looking like it's not perfect, but it is. 1 through 5, that's all 5 trials put together is high average. 3 minutes later, her recall of these is 70th percentile, and queuing didn't help much, partly because her score was so high to begin with. 20 minutes later, she retains what she remembers, so it's 84th percentile. Out of 100 people her age, 100 children her age, 84 children would do worse on that, whether it's free or queued. Queued, we just give the categories. The words are actually things like furniture and clothing. And we say, okay, tell us the clothing, tell us the furniture. Yes, no, we just read, we read 48 words. The 16 she heard, 16 she never heard, 16 she heard once, because we'd like to throw an interference trial too, to make it more difficult. And that was really fine. So her true positives, she was saying yes to the words that were heard, and she was saying no to the ones that were not from the original list. Okay, next slide. This is the Ray complex figure. We'll go to the next slide. And I'll show you, this is her copy of it, which is deficient range. I'm letting somebody in here, all right. So she could not draw this very well. Gretchen, if you want to just flip back to the original real quickly and show what it looks like again.
All right.
That's what it looks like. So it's right in front of the person when they're drawing it. Then you can go back to her drawing. So this is not very organized. You can see there's no rectangle there. It was really not a very well organized approach to copying this. If you want to go to the next slide, I'll show the recall of it. So here's the recall of this. And it's really classic that when people have trouble with the parietal lobe, then they will have more trouble drawing something hand-eye than drawing it from what's in their mind. So when she drew this from her memory, she's approaching the rectangle, it's more organized. It's really a pretty common sign of parietal lobe difficulties, that her visual spatial organization is better when she's drawing from within herself than when she's trying to do hand-eye. Okay, next slide. This is 30 minutes later, excuse me. And it's even a little more organized. These are still low though, in terms of memory, because you get scored for the organization of it as well as how much you recall. There's a lot of material there. Notice that as far as the temporal lobe and memory itself, there's a lot of material there. The score is low because of how disorganized it is. Okay, next slide. And if you notice her own opinion at 11 years old, she has no problems in diversity. She's got good friends. She's a great family life and home life, very happy child. But she's rating herself elevated for ineffectiveness. She's not doing well in school, and it's bothering her. She doesn't really know what's wrong, doesn't know what to do. And so the classic mood disturbances are not there, but there's a sense of ineffectiveness. Next slide. This is 2 years later when she has her first seizure. And it is a generalized seizure condition that shows up in the left central parietal region. If you see the report summary, the second line there, I can't get my arrow there, but actually that first paragraph of the report summary ends with seen over the left central parietal region. And then the correlations talk about primary generalized epilepsy. That's because of the way the EEG looks. Okay. And her MRI, I noted, was normal. So the MRI was not really going to give us any information of any relevance. It comes down to the EEG and the neuropsychology. So this is the initial intervention for her. Pharmacologically, she was given Depakote, 500 milligrams in the morning, 1,000 in the evening, Lamictal 125 in the evening, folic acid, and multivitamin. And then I had the privilege of evaluating her 6 months after that. This is now going to be 30 months following this pre-seizure evaluation where she turned up having JME. Now she's older, so I went to the Dallas-Kaplan executive functioning system as opposed to using the NEPSI, because I can follow this through into adulthood, whereas the NEPSI would end at 16. And I have apologize, I'm going to step aside. I need one moment. I'll be right back. Thank you very much. Okay, so you want to go to the next slide and we'll look at her evaluation now. I'm going to start with the California Verbal Learning Test. She's now 14 years old. All right. And I want you to notice at a glance that it looks good. It looks really good. This is primarily the left frontotemporal region. If you recall, her seizures were in the central parietal region. So this is not that much different. All right. It really wasn't that affected initially. Mathematics is also something we know to be related to the left greater than right parietal region. That was one of her first complaints in school, that math was giving her trouble. So this one looks really, really great. Now I want you to also notice that she's on medications now, which can have some adverse effect on a person's cognition, but they're not really affecting her verbal memory. It still looks really good. So she's got high average to average scores here all throughout. Okay, next slide. This is her ray figure. This is her copy. It looks really nice. It's 84th percentile. It's high average range now. This is what happened with introduction of pharmacological management for her seizures, that her ability for visual organization is back to where I believe it should be, because the rest of her skills are average to high average range. So it makes sense if she's going to have skills that are not affected by her seizure area that are high average, that this area should have been high average as well. And now that you've got seizures under control, she does this. Okay, next slide. This is her immediate recall. It's 88th percentile for her age. Very nice, very well organized and good memory. She had good memory before, it just was really, really very disorganized. Okay, next slide. This is the 30-minute recall. And it's 88th percentile. Okay, so you can see, I know this figure really well. So everything on the left, the lines are where they belong. The rectangle's missing a little bit, but it's still, the internal one is still there. The crosses are where they belong. The lines on the right are accurate. We actually will downscore the circle with 3 dots. If a person draws circles instead of dots, it's a frontal lobe sign. Somebody published a book on this, on those circles, a whole book, don't ask me. But if you draw smiley faces or you make open circles, that gets downscored. And this was drawn accurately. So there's no frontal lobe signs in this at all. It looks really beautiful. It's 88th percentile. Okay, next slide. This is her Dallas-Kaplan, which is what I use instead of the NEPSI because she's older. And I want to point out just what's in the arrows. Don't worry about all of it. You don't need to read all of it. The motor speed is now deficient. Her psychomotor speed, which looked fine before, is now in a deficient range. And that's a medication effect. And verbal fluency, letter and category. Letter had been high average. It's a little lower, but it's fine. It's now average range. Category, which is temporal lobe, had been high average. It's now average. Letter fluency was low average, and it's now average range. It's a little bit higher. So her thought organization is much better now on medication. And so she's doing better with the frontal lobe task of fluency. And 20 questions is something that it has to do with visual organization and also language. It's a pretty tough task. If anybody remembers the game 20 questions, this looks like that. It's on the page, you have all these visual images of things, and you have to pick out. I'll ask them, okay, like I know the answers, and on this full page of items, she has to figure out what it is. So if the first one is a sailboat, she's looking at about 50 pictures. She'll have to say, is it living or is it dead? Is it edible? And I'll say no, so she figures out what it is. So that's really, the process of elimination there was hard for her to do. But overall, like things look a lot better. Okay, next slide. So I want to stop for a couple of minutes here and then go on to the last part, which has to do with quality of life, because I want to see if anybody has questions at this point about student interventions, kids in either grammar school, middle school, or high school. There are 504 plans and there are IEPs. And I don't want to see if anybody has any questions that relate to that, or if we want to wait till the end to talk about everything. I leave it up to the group.
Okay. Let me see here. Are there any questions? Would you all, if anybody has any questions, why don't you put them in the chat box and we'll address them at the end. Maybe that way we can keep.
Okay. All right. How are we doing for time?
Let's see. Well, it's 6:48 and the webinar can go from 7 to 7:30. You have time.
Okay, well, I'm just going to go through. I have this YouTube, but I think I'll just go through the slides and then we'll see what kind of questions we have. And I can always go back to it because we'll probably be talking about school interventions, and so we'll go back to this slide then. So let's go forward.
Okay. Oh, sorry.
I want to finish up and leave time for people. Okay, so quality of life. You know, when I started working in this field, it was my thesis work for my PhD, and I didn't shout at meetings, but it used to really freak me out listening to neurosurgeons talk about, they would present their information on like their center, and they would talk about the success rate from surgery. And there was only one thing that was being measured, and that was how many people were seizure free. And I was working with patients, so I knew, like, if sometimes people came out of surgery, like after the right hemisphere, more so than the left, and they had emotional difficulties, that would definitely because of the surgery and having their right hemisphere altered. But that wasn't counted as part of the success of the surgical procedure back in the 70s, only whether you were seizure free or not. And I didn't feel like that was good enough. So my early work was in this and remains in quality of life issues. So I think people started getting on board back at that time. So somewhere around the 80s, groups like the Melbourne group, this is Australia, they started focusing on their quality of life measures that looked at psychological and social adjustment. They looked at what the seizure onset cost the person. And, you know, in the sense of like how much they would lose control of their life and have that sense of like, you know, self-control. They started to measure and look at carefully like limited or pervasive loss, extensive process of personal reevaluation, like a sense of who am I now? Like, you know, how does this affect me? How do I go on to be a quote unquote normal, you know, live a normal life? And they started to compare this to what happens to people after trauma, as if there was an element of PTSD in being diagnosed with epilepsy, which to me made a lot more sense than just talking about, you know, surgical relief. Next slide. So in the future, there is a lot of work going on now to kind of redefine the actual tools we use to measure quality of life in patients with seizure conditions. Flexible tools that can make them more available. Like I'm in an academic teaching hospital, so I have the privilege of being able to do anything that's available to use, but many smaller centers, many smaller hospitals in rural areas, in other parts of the world don't have these tools, don't have this type of thing available to them. So there's a lot of work being put into making these more clinically available. And then the telehealth is really, COVID, one of the silver linings is the use of telehealth. And I don't think it's ever going to go away. I think it's here to stay now. And that makes it more available, even to just complete questionnaires and interview patients from their own homes in rural areas, in areas where they wouldn't otherwise be able to get to an epilepsy surgical center or any other type of epilepsy center. Some of the smart technologies, there's one, really one of my favorites that I won't go on about, but it has to do with medication management. And there are many of these now, and the prices have come down, and they just make people's lives much more manageable and allow a person to be much more independent, whereas they might need somebody to be with them all the time in the past. So I have to say lifespan work is really important for quality of life because there has to be somewhat of an individualized approach to treatment plans for a young person developing an epilepsy condition, whether it's a localizable one that's amenable to surgery, or whether it's a generalizable one where they're going to have to live with the condition for the rest of their lives and have to be involved in medications. So I see a question from Christine, and I think that we might be able to just approach that right now. So you want to start?
Yes, let me pull that up.
Yeah, let's leave this slide up for the moment.
Okay. I just need, okay, here we go. Let me find the chat. Let me see here.
It had to do with a child who had developmental disabilities and then developed their first seizure at the age of 16.
Okay.
I didn't see the rest of the question because I couldn't actually see the rest of the.
If you can hear me, I'll just ask it.
Yeah, sure. Go ahead.
Okay. Well, I'm just, this is kind of new to us, I guess. I mean, my daughter's first seizure was when she was 16, but she had been diagnosed with autism when she was about 2.5, and it was initially diagnosed because she wasn't speaking. When she has seizures, she loses her ability to speak for a while. You know, she had, a handful of seizures. They put her on medication, but that's like it. You know, she's just going about life. Like the seizures or the medication is controlling the seizures, but I don't know what's attributable to autism and what's attributable to the seizure issues. I don't know how to get her the right help. And a lot of the symptoms that you were describing, like she wasn't speaking because of autism, but I think that's a problem with the seizures. Like I don't know how to pinpoint what the source is to help her with the issues that she's having because of it.
Yeah, understood. So, Gretchen, this might be a challenge for you to go back to the slide with the 2 arrows.
Okay, I'll give it a shot.
Yeah, and I'm going to try something too while you're doing that.
Okay.
And we've never really even been given, I mean, her medical records are saying she has a seizure disorder, but no one has ever really said anything to us more than that. And then they give the medication and say, well, let's follow up in 6 months. And that's about it. We don't get much more than that.
Yeah, I hear what you're saying. You want something more comprehensive.
Yeah.
And you have a sense of what to do, to
Right.
build a foundation for her future for her.
Right. I mean, she's managing to get by, but it's extremely stressful.
How old is she now?
She's 18.
She's 18. Oh, so that wasn't that long ago she had the first event.
Right.
Okay.
Okay, I think I'm soon there. Let's see. Was that the one you were talking about?
Yeah, let's use this just as a backdrop to this conversation, because this goes back to the current thinking that what she's, her conditions are they're linked.
Right.
She had a higher vulnerability for having a seizure condition because she had autism, but they're not unrelated. And so the thinking about, I didn't try to get too bogged down in the biological babble, if you will.
Mm-hmm, mm-hmm.
The reason for generalized difficulties that you can't address them with any kind of surgical condition or any kind of surgical approach, there's no way to get rid of the seizures, so to speak, is because the genetic difficulty has to do with the neurotransmitters. So all the cells are involved. So there's something that goes awry with one of the neurotransmitters that is involved in regulating a brain being overactive. Some of our neurotransmitters like downregulate, and some of them activate.
Mm-hmm.
So one of them that activates is called GABA. If it doesn't work right, we're going to have overactivation. And so when there's something wrong with the neurotransmitter, the area where it binds, then every cell is involved. So that can cause a lot of different kinds of problems, including her difficulty, her early one. Mm-hmm. It doesn't mean that she necessarily had seizures before they were going undetected. So there's nothing you missed necessarily. It doesn't mean you missed anything. It probably just was that condition that now she reached a certain age where her hormone levels reached a certain level, and it triggered the first seizure event.
Well, interestingly enough, she was having problems with very painful periods and had just started on oral contraceptives to help with that right before the seizure incidents really started.
Yeah, and I have patients who will tell me that they had periods, from the time they were 12, 13, but then they went to the doctor when they were like 19 or 20. They had terrible pains in their abdomen, and the doctor figured out that they were having cramps, and they were told that, and I've heard this more than once, they were told that their hormone levels were not high enough for them to experience cramping.
Oh.
And what had happened to them is that at the age of about 18 or 19, they suddenly had enough hormonal response. So they weren't even ovulating before that.
Mhm.
Well, they never had any cramps or never had any pain. So she may have just finally reached that level of hormone
Yeah.
to cause cramping, to cause actual ovulation. And that's when she thresholded high
Yeah.
enough to the seizures begin. So that's
Well, and I don't want to take up, all of your time, and I'm sure a lot of people have different questions. I just don't know where to go to get her more, like you said, comprehensive evaluation and maybe better care.
has she had a neuropsychological evaluation, or is she,
No,
even if she's not fluent, she can still be evaluated? I don't know how far away you live. Where are you?
we're in Pittsburgh.
Okay, well, I mean, Pitt should have some epilepsy center there. What
Okay.
you want to track down. We also have, we have here at Hershey, I'm just describing it, you check at Pittsburgh, a center for developmental difficulties, and we have neuropsychologists in that center. I actually follow children that were born with cardiac problems, and they often have autistic traits or outright autism. So I do evaluations on babies, 12
I mean,
months.
she has a neurologist that she sees. Would he be able to direct us better, or?
He would, yeah. And ask him,
Yeah.
tell him you would like to have her seen by a neuropsychologist. I'm seeing a message here from Emily.
Okay, thank you.
Neuropsychology here in Pittsburgh. Can everybody see the chat?
Yeah, I can, the neuropsychologist eval in Pittsburgh with Dr. Sarah Loughlin at Children's Hospital in Pittsburgh.
Okay.
That's
Excellent,
Emily
good.
wrote that.
I've got the chat open too now. Now it's working for me, good.
Thank you so much. I appreciate it.
But she's gonna need that kind of follow-up with people that
Yeah.
are specialists and autistic specialists, for the rest of her life, so.
Yeah, okay, thank you.
Sure, yeah, let's see what else, anything else, anybody want to just speak up if they want something addressed? I'm seeing, Alicia's comment here. So you had evaluation 3 years ago, and are you getting, or do you have a routine reevaluation planned?
So we go to Children's Hospital. So we seen a gentleman there, and he said to follow up in about 3 years. But that was pretty much all it was. He just said to come in. So I'm going to try to contact his office. If not, I was going to see the neurologist is the one who sent us to him. So I don't know if we need to get like an order for it again, or if I could just schedule it.
Well, it's a return, but it's 3 years later. So you can call and ask to be a return patient, but the schedulers may have to go get a referral, but you are going to be a return patient. So even though it is 3 years later.
Okay.
Now, what about I'm seeing this question, what do you suggest about getting the school to actually implement the information to the IEP? That it should be based upon that information. The neuropsychology exam should be given to the school officials to use. The neuropsychologist is the one that writes the recommendations for the IEP.
So my issue was I took the test to them. I said, hey, we're getting this test done. The doctor said it could help us learn more about how her brain is working with her learning. They said, great. They had a bunch of administration switching around. And then they're like, well, we'll address it next year, because now by the time they wanted to do it, it was May. So the next year follows, and we go, and I want to pull this information up. Please contact him. Pull whatever you need to from this. And it kind of just was pushed under the bus. We were also in a private district, so I switched over into the public school district now. But we've kind of had some issues with that too. Like I'm trying to fix her IEP, and I feel like they're trying, but she's getting ready to go to high school. And now I'm so nervous that, we're going to start all over again. And I have to get these people to understand these are what are the problems that she has revolving around her epilepsy. She was a straight A student. And then the more seizures she has, she's completely failing at this point.
So I know by
And
law, if you put in writing, even like 1 or 2 sentences, you put in writing that you want, a school psychologist evaluation. They have to at least do the IQ and the achievement, but I tend to let the schools do that and do the neuropsychology evaluation myself.
Okay.
So you need to have the initiative to get the neuropsychology evaluation, but then you can request in writing that they provide the Psychological Evaluation, the school psychologist, and that they have an IEP meeting. You want that meeting to occur sometime in April or May to get ready for the fall. Don't let them wait until the fall to do it, because then they'll just drag their heels until December and January. So
Okay.
yeah, it's the only thing I know by law is that once you put in writing that they have to within 30 days schedule the evaluation. I've seen schools do that where they get the parents to request it in July, and they get a letter back in August that says they scheduled it for January.
Hmm.
They've met their legal requirements. So you really want to push hard.
Okay. Thank you for that.
Yeah, sure. This is great. This is great networking here in this chat. I think it's wonderful.
Okay, did you want to answer the other questions in the chat, or wait until you're finished with your
No, I
presentation?
think we're going to leave this. We're going to leave this right here until the next question. I think we're ready for questions.
Okay, all right, great. So, yeah, we do have a question from, let's see, Emily Marino. She says, my daughter has had a right hemispherectomy and typically has a neuropsych eval yearly after her surgery, which was 2 years ago. Ideas for technology to help her with education now.
Okay. How old is she?
She's 12.
Okay. Yeah, so she's in middle school or just about to begin middle school in September?
7th grade, yes.
Yeah, I know everything's a mess now with COVID. It's hard to know where anybody is. So, yeah, it's the right. Having a right hemisphere difficulty is a lot harder to characterize and understand than the left, because the right hemisphere is going to be much more involved in emotional processing and emotional development, so that she may have a lot going on with her that is not all that obvious. She's just acting, sometimes strangely, to be blunt about how the teachers will see her.
Okay.
She's not going to be as organized in the way she processes information. She may also have more difficulty now picking up social cues like tone of voice and body language and facial expression. So
Okay.
some of that's not going to be as obvious as if she had trouble with, verbal memory, for example. So I think some of the technology for someone like her would have a lot to do with emotional, with helping her understand social context for things.
Okay.
So yeah, I would say as far as how is she showing? Like how's she doing in school? What's going on?
She does well overall. It's she's in a private Catholic school, so we don't have either a 504 IEP. We just use the neuropsych eval as recommendations, and for the most part they do. But where she struggles the most is math. I think maybe, and that teacher in particular seems to not understand the best of her abilities. So we're just struggling with COVID and so much of it on the computer, of ideas of things to help her.
I will say she was young enough that she can develop her left hemisphere skills. It's remarkable. It really is how much the other hemisphere can pick up and develop. The younger, the better. She was young enough. But she's going to have a lot more difficulty visualizing things, and we'll have to grow into that. And so anything that you can do that would allow her to visualize, this is where getting an iPad, being able to see things, certainly with mathematics, and anything you can do to help her be able to see what she's dealing with will help her.
Okay.
Even what kind of math is she doing right now?
Pre-algebra.
I was about to talk about algebra. Yeah. So if you can lay out the simple quadratic equations with visuals, maybe you could find. There's so much stuff online that and don't pay a lot for any of these things. Really, before you spend a lot of money, email me. There's just so much out there, and parents just are forever getting, I don't know a right word, ripped off. There's so much stuff that's out there. It's all marketing. There's some basic skills that can be developed using visual tools. And I would say, yeah, because she has a hard time visualizing. She has a hard time organizing. She's going to have trouble with left and right. So if you're trying to, picture something like geometry in high school, will be very difficult for her.
Okay.
But she can benefit from visual approaches to like any kind of hands-on to help her see it. I mean, I'm thinking at a higher level, like high school, looking at circuit boards. You know, if she's actually doing something like welding something, putting something together, like making a small Heath kit, would be a lot easier for her to understand than if she's just trying to read about or study, you know,
Okay.
electricity.
Okay, thank you. I appreciate it.
Okay. All right. Barbara Smith says, my granddaughter is 7 months old and was diagnosed with seizures at 6 weeks old. She was diagnosed with infantile spasms at 6 months. Please tell me what is the youngest age for evaluation. The causes of her seizures have not been identified. Her physical development is greatly delayed.
Okay. We have, and you know, any major center will have these. We have people that are developmental specialists where you might want to just consider genetic testing to find out, like you say, you know, there's no cause for the seizures. There may be some genetic continuum of why she's delayed and why she has seizures. As far as evaluation, she can be evaluated at her age. You can evaluate babies. She can certainly be evaluated by 6 months old. So she's 7 months old. She can be, there are pediatric test kits that pediatric specialists like myself will use. They look like giant toy boxes, but we're looking for developmental milestones with having a child on a blanket or on a mat and just having them do things that they can do. At her age, she might be sitting in her mom's lap while she's being evaluated, or in your lap. And we can go through things we expect to see for her age, like whether she responds to a stimuli, you know, make a sound, or we have certain tools we use. So she can at her age, she can be evaluated. And then you might want to try to connect with the center so she's going back to the same team so they can follow her. And it's a much better way to have a child's developmental course monitored, to have the same team see her as she's growing.
Thank you.
Oh, you're welcome.
Okay, and it looks like Mia Carlino just put a quick note in here if you all didn't see it. Watson Institute or AHN will do the neuro psych evaluations for children over 8 years old. I believe that was what she was referring to. And then let's see here. Emily Marino added some good information. Check our Brain Recovery Project website for IEP help and legal help and rights best resource. So let's see, okay, and is there a website for that, Emily, or?
It's just the Brain Recovery Project. They actually, if you're considering surgeries or anything, it's a wealth of resources, but they really have an excellent area of IEPs help there.
Oh, that's great to know. Thank you. Thank you so much for that wonderful presentation. It was great. And, you know, once again, I would like to thank our generous sponsors, LivaNova, Aquestive Therapeutics, Zogenix, Greenwich Biosciences, and UCB. Let's see, and Neurelis. So that will conclude the webinar, and I hope that you all stay safe and healthy, and we hope to see you at the next webinar that we have.